My name is John Hambidge. I'm a consultant orthopaedic surgeon. I work at Queen's Hospital in Romford. I'd like to spend some time today discussing with you some aspects of safeguarding. We all do safeguarding as part of our annual assessments. We should know a lot about it. What I'm going to do is I'm going to illustrate a few cases that came through our department over the space of 1 week, from which we learned different aspects about safeguarding. The first case relates to this young child. The story is it's a 9-month-old child who had been brought to the department the day after an injury. The mother gave the history that the child at this time was under the care of a nanny or a friend who had been looking after the child, and that they'd taken the child to a toddler and parent group. The child themselves was able to stand and ambulate a few steps, and the history was given that during the course of a playtime, the child had been pushed from a child's slide and had fallen approximately 6 inches, sustaining injury to the leg. The childminder gave the history to the mother that the child had cried but had been consolable. And then after that, settled and would have been returned to the mother at the end of the day. When the child had come to our department, the child had been assessed using standard safeguarding tool in the emergency department, and no serious risks had been identified for the mother. The child was seen by one of our paediatric team together with the child, and it was felt that there was no immediate risk to the child because the injury had occurred in a manner which was thought to be consistent with injury sustained. The orthopaedic registrar was informed of the case, but managed this without seeing the child and advised that a plaster back slab be placed. My involvement came a few days later when the child appeared in my fracture clinic. And in the meantime, the Metropolitan Police had contacted the hospital because the mother had raised concerns that the child had sustained injury while in the care of a childminder. The childminder had reported the injury, but there was still some concerns. So the mother had contacted the police in turn contacted the paediatric safeguarding lead for the trust, and he in turn informed me. So on the day the parent arrived, the child protection officer was there with me, and we saw the child together. He didn't identify any risks to the child from the parent, but noted the history as given by the mother. And I decided, following review of the x-rays, that this child should continue with non-operative management, though the two of us agreed that in the history of a fall from 6 inches was not compatible with the fracture of the distal femur seen on these x-rays. The story then developed that I was contacted shortly after this by the Metropolitan Police, asked to give a statement to say at what time did this fracture occur. And I fortunately attended a conference a few weeks before where we'd spent a whole of an afternoon session discussing that very issue. The only thing we can say is that in the absence of callus on the x-ray, that the fracture was less than 7 days old. But this was not the information the Metropolitan Police were looking for. They were hoping that I would be able to give a specific time of the fracture to the 2.5-hour window where the childminder was in charge of the child. And it would appear that on the basis of a lack of evidence, the case was then dropped. It was a few months later then that I got another phone call from the Metropolitan Police asking me to again give a statement. It would appear that in the meantime, a second case had come to mind where the same childminder had been involved in a child who was later admitted to Great Ormond Street with a severe head injury, and it turned out it had been shaken baby syndrome. If we take the case a little bit further, I can now know that the mother was successfully prosecuted, and not the mother, the childminder was successfully prosecuted and is now currently serving a jail sentence. We spent some time reflecting on this case and what lessons we learned. And we believe that we did the right thing by managing the child in front of us and that we agreed that we did not put them at a place of risk. However, perhaps we should have taken the case further with the Metropolitan Police in terms of the childminder's history And if we'd have followed the regulations and admitted the child directly when they were seen in the emergency department, perhaps the second child wouldn't have come to harm. So reflecting a little bit on paediatric cases, inflicted injury is a common cause of injury, and it should be suspected whenever you see significant musculoskeletal injury under the age of 18 months, but it can occur at any time. Unfortunately, child abuse is a leading cause of mortality in infants and children, and 80% of head trauma in children is under the age of 2 is in the form of abuse. The diagnosis of abuse is frequently difficult, and you have to consider all sorts of clinical factors, but also factors to do with the child themselves, and their social behavioural factors go with it. There are some clues. Multiple fractures at different stages of healing are suggestive of physical abuse. And if we look at the X-ray at the bottom, we can see a healing fracture of the tibia. And if this had been the X-ray on a presenting case, as it was, then it suggested that this injury would have taken, say, some time previously and didn't fit with the history presented by the parent. But there are some fractures, metaphyseal fractures, and particularly fractures around the chest wall with rib fractures, scapular fractures, and sternal fractures, all indicating a high risk that this is an inflicted injury and may indicate that there is safeguarding issues. We know we're not good at it. This is baby P, the 17-month-old who died with more than 50 injuries that had been inflicted over an 8-month period. And during that 8-month period, the child was repeatedly presented both to child services and to the National Health Service. So the child in front of you, this may be your chance in order to prevent the development of this pattern of injury going on. And though baby P was a very severe case, it's easy to think it was a one-off. However, these are the X-rays taken of a child who was admitted some time ago, again to Queen's Hospital. The presenting complaint was a fracture of the left femur, and this can be seen in the X-ray on the top right. But also you can see in the X-rays of the top left, the healing fractures of the ribs. And these are the metaphyseal fractures on the bottom of the left distal radius, the right distal tibia, and the left distal tibia. And we were able to identify in a skeletal survey 26 separate fractures in this child, which turned out to be one fracture for every 2 weeks they've been on this planet. So unfortunately, these cases are not isolated, and if we pay attention to them, we may be able to prevent the child going on and coming to a tragic end. The parents of this child were arrested on our ward and again are now serving time in prison. So is this a case of inflicted injury or not? We can see here that there is abnormality to the proximal tibia, proximal femur, distal femur, proximal fibula. No, these aren't. These are a congenital anomaly. And we've got to be careful that we don't inadvertently or misdiagnose inflicted injury, because the consequence of it to the family dynamics can be very severe. But our duty in these cases is clear. When we have concerns about safeguarding children, we have to place the child in a place of safety, and we have to inform the paediatric safeguarding team, who will then investigate and take things further. So it just happens in children, does it? Well, let's again reflect on another case that occurred about the same time, again seen at Queen's Hospital, Romford. This is a 19-year-old young lady who attended the emergency department at Queen's Hospital with a female about the same age. The history presented was that the 19-year-old lady had been in a fight with her partner. Her partner had picked up an object and had attempted to hit her on the head, and she'd used her left arm as a defensive mechanism, sustaining this fairly classical nightstick injury with a transverse fracture of the ulna, and we can see the open element of it on the soft tissue view on the other side. Again, adults have been through a similar safeguarding process when they arrived at the emergency department, and these questions have been asked. The 19-year-old young lady declined to be admitted to the hospital at this time. She went home in the care of her female accompanying person, and they went back to the ward the following day when they were admitted, and this young lady underwent debridement of the wound and plate fixation of the ulna. The learning point from this was, who was the female? It's very easy for us to assume things. Could the female have been the partner who had actually assaulted this young lady? Nobody appears to have answered those telling questions. And thankfully, this has a slightly better story to it, in that, yes, the lady who accompanied her was a friend who had persuaded her to attend the emergency department. And while this lady was on the ward, we were able to ask her questions when she was separated both from her partner and her female friend. And we were able to direct her to social services in order for her to help to escape the abusive relationship. So domestic violence is very common. It's estimated that 8.5% of the female population of the UK and 4.5% of the male population of the UK suffer some form of domestic abuse. So it's more than 100,000 people in the UK who are at risk of serious injury or even death as a result of this. And it's estimated that 7 women a month are killed by a current or former partner. And I've recently read an estimate that 2 men a month are killed by a current or former partner. We've got to remember that if there is children in the homes, then we also have a duty of care to the child if we are concerned about domestic abuse. Because 62% of children living in houses with domestic abuse are either harmed directly or will have witnessed the abuse of others. And again, the bottom line takes us back to the same sort of message as we had when we were thinking about paediatric abuse. 85% of the victims have attended 5 or more times seeking help before they were actually identified. This could be this lady's presentation calling for help, and we have to give her the opportunity to be able to express her concerns. Our duty of care with adults is slightly different, but we should take the opportunity to take a history from this lady when she is not in the presence of anybody who could be her abusive person. We've got to remember that it occurs in same-sex relationships, and it occurs between men and women in both directions. So the final case I'd like to discuss with you is the case of an elder who was brought to our emergency department with this fracture of the distal femur. There is evidence from that x-ray that this is not an acute fracture. There is some remodeling of the distal femur. This was one of our first concerns. The second concern is you can see the flexion deformity of the femur at the knee, which suggests this is a patient who is non-ambulatory, somebody who does not walk, and the bone quality is very poor, suggesting osteoporosis. Turned out this was a lady from a nursing home who had had a fracture of her distal femur. The caring nurses who came with her couldn't really give a time for when the fracture had occurred. They'd noticed, however, that there was pain when they managed this lady, and then noticed a deformity of the distal femur. This lady again was admitted for safeguarding issues, but the sister on the ward drew my attention to the fact that the nursing home seemed to be very caring. They sent a nurse each day to come and accompany this lady through her meal times, so that a friendly face could help her to take her meals. And this didn't seem to be compatible with the idea that inflicted injury had occurred. We had a number of these cases over a period of a few months. We admitted 3 or 4 patients with very similar looking fractures of the distal femur, all coming from nursing homes. Not the same nursing home, but different nursing homes within our take area. After a little bit of background work, we found that the nursing homes had been provided with a new type of hoist, one where the legs were held in a more extended position. And when the patients were being moved around the often confined spaces in the nursing home, inadvertently the legs would sometimes make contact with the furniture, the wall, the door of the bed. And in the osteoporotic case, this was enough to fracture the femur. So this wasn't an inflicted injury in terms of somebody deliberately inflicting injury. This was an inflicted injury because of somebody using equipment that wasn't appropriate or didn't fit the bill. We drew the attention of the social services to this, and they made changes to the hoist provision in the nursing homes, and we managed to stem this tide. So sometimes reporting safeguarding issues isn't an indication that we're accusing people that they are causing injury by neglect. We're simply drawing attention to the fact that there may be some fault in the care of the person due to lack of equipment or lack of knowledge that can be corrected and save further people from sustaining injury. So elder abuse occurs and is defined as an intentional act or failure to act by a caregiver to another person in a relationship involving an expectation of trust that causes or creates a risk of harm to older adults. And I think this definition could be used as an indicator of abuse in all relationships where we have somebody, where there is an expectation of trust between the two people involved. So let's just reflect a little on what we've learned. There are safeguarding policies available in all trusts, and these are normally worked through with the local providers of safeguarding and the hospital safeguarding personnel. They should be available to read, and they contain some helpful information. But just occasionally we see cases that we need to raise, and we should not have any hesitation in raising our concerns about whether this is safeguarding or an inflicted injury, particularly when there is a understanding that all of these cases that we've seen contain potentially life-threatening conditions. And if we fail to identify inflicted injury or to raise safeguarding issues, we may put that person or others at risk. We should always consider it when dealing with children, especially those with injuries under the age of 18 months, and especially adults, both the vulnerable and the elders, though we've also seen in our case presentation that can occur in any of the domestic situations as well. Many thanks for your attention.